I'd like to welcome you to today's Medical Center Hour. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities. We offer these programs each week, barring snowstorms, and are delighted to see you all here today. The School of Medicine's annual AOA lecture was supposed to be offered today by the distinguished physician scientist, Dr. Aaron Vinnick from Eastern Virginia Medical School. Regrettably, Dr. Vinnick fell ill on Monday afternoon and had to cancel his visit to UVA. This was most regrettable, and not only for the Medical Center Hour, but also for the Alpha Omega Alpha Honor Society, which was very much looking forward to hosting his talk. But as luck would have it, with incredible cooperation from these four remarkable women and the local Live Arts Community Theater Company, we have arranged another program for you today: Women, Medicine, and the Vibrator play. This represents quite a shift from the AOA lecture. But we hope that you'll find the hour of great interest. So, Women, Medicine, and the Vibrator play. Viewing women through Western medicine's androcentric lens, physicians from Hippocrates and Galen forward explain some women's behavior, everything from headache to quote-unquote troublemaking, as unhealthful signs of hysteria, a suffocating madness believed due to a wandering womb. Centuries before Freud asked, "What do women really want?" medical men assumed they knew what women with hysteria needed, and that remedy was pelvic massage to paroxysm. By the late 19th century, with manufacture of electrified massage instruments, doctors could deliver said therapy for hysteria even more quickly and efficiently. This medical treatment, and it was a medical treatment, the Victorian social milieu in which it was prevalent and popular, and certain understandings or misunderstandings of female sexuality, intimacy, and gender and social inequality are the subjects of young American playwright Sarah Ruhl's comedy, In the Next Room, or the Vibrator play. Her play was a finalist for the 2010 Tony Award for Best New Play. We've invited four panelists to explore the rich mix of ideas having to do with women, medicine, and the Vibrator play. We welcome Alison Booth, professor of English, who is well-versed in Victorian culture. Julie Hamberg, the artistic director at Live Arts downtown and director of this play. Dr. Anita Clayton, professor of psychiatry and neurobehavioral sciences and clinical OBGYN, much of whose research and clinical work has to do with female sexuality and female sexual dysfunction. And finally, Anne-Laure Talbot, who is in the MD-PhD program here, a member of the graduating class of 2013, who is the producer of Sarah Ruhl's play for Live Arts. By wonderful coincidence, Live Arts is presenting Sarah Ruhl's play right now, all month, up until the 23rd of this month, and we encourage you to go down and see it. Last Saturday night, more than 20 UVA medical students attended the play. And we hope that today's discussion will prompt you to take in a performance before it closes on the 23rd. So welcome, and we look forward to a rich discussion.
Thank you, Marcia. It's interesting to be on this side of grounds. I feel neither expert on the drama nor expert on medicine, I assure you, but I am an English professor. And I'd like to talk to you for about 8 to 10 minutes, each of us will be planning to go around that long, about different kinds of timeliness. Marcia already mentioned one of them, which is that the play is being performed right now. And I think this is an absolutely extraordinary play, and I think they've done an excellent job of putting it on. I thoroughly enjoyed it. I laughed, I cried. You will really get a treat. And I would highly recommend spending time on the exhibit in the hallway of Live Arts by the dramaturg, Christina Dobrovich. And it really does give you a synopsis of the history of medicalization of women's sexuality. So that's one kind of timeliness. Another is sort of reflections on the timeliness of this in my career. I am a Victorianist. As I was coming through graduate school, feminist studies sort of grew. I mean, there was hardly any such thing before around that time. This is back in the Victorian period, by the way. She says, I know the Victorian culture. Yes, and in fact, I think possibly my grandparents were raised as Victorians. I think a lot of us still are Victorians in many ways in the United States. But feminist theory really took hold of insights into the history of the treatment of women, and has really thrived in Victorian studies. And I just want to put out there that this is a kind of timeliness, or anachronism if you want to say, that it's easier to talk about gender and sexuality issues historically than if it looks like it's right today. So this is true of my students who love the Victorian period. They love to read novels in which they see other women are being mistreated, and it somehow puts a certain amount of distance on what might be otherwise difficult to even recognize issues. In feminist theory, circa 1990, people started theorizing the idea that woman is nature, man is culture, the body is feminine, the mind is masculine. Technology got, among certain feminist theorization, technology could be seen as masculine, as patriarchal. Aesthetics, too, could be seen as a system for objectifying women. The professions were clearly organized as guilds to prevent women from practicing them. And of course, heterosexuality was heteronormative and oppressive. Feminism is the theory, lesbianism is the practice, would be a popular phrase. Now, all of those ideas have been relentlessly complicated even at that time, but I'm throwing them out there as kind of insight. Sarah Ruhl's play really tries to amplify on that kind of symbolism. And I think you would really see it performed in a very complex and interesting way. And as I say, it's always interesting, always easier to deal with things historically. It's a historical play. It's a play set in the 1880s. So let me say just a word, sort of timeliness about Sarah Ruhl, about the play. I'm really heartened by the fact that she's 38 years old. She's not my generation, so she's writing feminism. It's wonderful. I hope some of you have seen her plays. I think she's fantastic. She's a MacArthur Fellow, which I always think would be one of those timely things to get, wouldn't it? This 2009 play was a finalist for the Pulitzer and Tony Awards. And she's had a number of successful plays. Some of you may have seen them. The Clean House was also a finalist for a Pulitzer. Live Arts has performed a couple of her plays, Eurydice, which I think is wonderful. One of the things I like about Sarah Ruhl is she's not a hyper-realist play. She's not a playwright. She's not, the play you might see at Live Arts right now is working with George Bernard Shaw conventions, but she's also capable of working with Euripides or Sophocles. Eurydice is a wonderful play that was put on by Live Arts. The Clean House they also put on. And she says that she's interested in pre-Freudian psychology, and I think that's kind of an interesting point about the play that's being put on right now, but also about some of her other plays. She's very interested in medieval passion plays, and one of her cycles of plays is called the Passion Play. She's also interested in the theory of psychology, which is not Freudian, but thinks about the humors. And in the Sarah Ruhl play that's being performed right now, In the Next Room, or the Vibrator play, there's lots of wonderful play with the idea of fluids. Because the medical theory about what was wrong with these women was there was too much fluid in their uterus. And so you just have to push the fluids from one part of the body to normalize what's going on. And it's wonderful for a playwright. It's like a gift to a playwright to be thinking that the way you feel is all about liquid, because then you can talk about beautiful fluids. But there's a lot of other kinds of imagery in the play, but that's and that's sort of what I wanted you to know about Sarah Ruhl. So the play comes from 2009, as I said. So another kind of timeliness, the historical timeliness of the play itself, its treatment of historical issues. Briefly, the play unites a lot of historical elements, and that's one of the reasons I like it so much. She has characters specifically dealing with the invention of electricity. So there's great stage business of turning the lights on and off, but of course the vibrator itself is electric, and you can imagine the humor when it fails and things like that. So electricity, but that would be one of those inventions that the feminists might see as masculinist technology, perhaps, but the women love it. Some of the women do. Medicine, obviously, is the main theme, the medicalization of women's sexuality. Aesthetics, one of the things I love about the play is she brings in a character who is straight out of my field, an English artist who explicitly talks about John Ruskin, his friend who, on his wedding night, freaked out, and this is very historically true, freaked out because he discovered that his wife had pubic hair. Because he had only seen the female body in classical statuary. This is absolutely historical truth. At least it's true in a lawsuit which brought about the annulment of his marriage. So John Ruskin, the authority on art, this character is a pre-Raphaelite painter. That's essentially what's going on, and I love it. Any Victorianist like me is going to love the play for, I get the reference. And it's very funny, because you think of the doctors as being the ones who are avoiding dealing with the actual female body, and it turns out it's also the artist. The artist is idealizing, aestheticizing, objectifying. He can't even quite look at the woman, he has to look at her soul 2 inches in front of her face. So that's a really wonderful little bit. It deals not only with the medicine, but with the aesthetics. And just broadly with the objectification and idealization of women. A couple of other historical ways that this is a timely play set in the 1880s. Some of you may be familiar with Charlotte Perkins Gilman's story of 1892, The Yellow Wallpaper, which she claimed taught we're not to use the rest cure. I don't think it was quite that successful, but a lot of the ways women who were unhappy and miserable were treated was put you in a dark room, forbid you to do anything, sensory deprivation, perfect cure for depression. It's really... one of the characters in the play says, I get nothing but rest. Of course you've tried rest, so the vibrator is going to help. Other little bits of contemporary medical thought that appear in the play, notions that women, about what women should eat. There's a reference to small women should eat large animals, which is sort of funny, but just very dated, specifically Victorian notions about the body. A lot of talk about fluids that I mentioned. The mother is going through a kind of classic case of postpartum depression, and they bring in a wet nurse because her milk is inadequate. And that's another wonderful sort of historically accurate theme that the play brings in. And then, of course, it's really timely in dealing with hysteria, because a few years later, Freud was going to be developing the talking cure for hysteria. Now, finally, I just want to talk about the timeliness of the play today. As I said, it's easier to deal with these issues in a kind of historical framework. How many of you have seen the 2011 film Hysteria? Yeah, it's certainly going to remind you of this, which, it's not as successful because it has other, it's written by different people. Sarah Ruhl was better at this kind of thing than most people. Directed by Tanya Wexler, written by Stephen and Jonah Lisa Dyer, with great performances in it, Maggie Gyllenhaal, Hugh Dancy. I recommend the movie, but it seems not a coincidence that the Sarah Ruhl play and a play which deals with very much the invention of the vibrator as a treatment for hysteria. Obviously, calling it the vibrator play recognizes the vagina monologues and the importance of theater, which we'll be talking about later, for dealing with medical issues. 50 Shades of Grey. People are trying, women are trying to figure out their desires, their sexualities. There is really regrettably slow recognition of women's health as a distinct set of issues. And I think you can see that this issue is not just a Victorian one. And then a set of questions that I think if you see the play you'll be interested in, and I don't pretend to exhaust. The play really is aware, it's not a Victorian play, it's a it's a current feminist, post-feminist play that recognizes cultural studies approaches to race, class, and gender. It's incredible to me how well she brings all these together. And one of the wonderful things about the play is there is a kind of solidarity among women that is not just class-based, and is less successfully it is cross-race. Less successfully, you see what you think about the play. But that makes it really encouraging to me that Sarah Ruhl is writing this play right now. So, thanks.
Hi everybody, can you hear me? Yeah. Okay, I'm Julie Hamberg. I'm Artistic Director at Live Arts. You guys may or may not know what Live Arts is. It is a community theater that's downtown, just off the mall. It's on 2nd and Water Street. We try to do plays that are a little bit more challenging than your average community theater. You are welcome to join us at any time, on stage, off stage. It is about literally the community making theater together. So this time we're doing In the Next Room with the Vibrator play, which most community theaters do not do. Because yes, there are women having orgasms on stage, you guys. So I'm going to tell you just a little bit about the play itself, okay? When you see the theater, it is set up where there is a living room and then the doctor's office. And so the setup is basically a doctor in the 1880s. We've actually set it just a smidgen later than that. It is the doctor and his wife who they have just had a baby, and she's having trouble having her milk come in, and they're looking for a wet nurse. And what is happening is he has a very successful business treating women who have hysteria. And he treats them with the, let's see, I'm trying to remember what the exact term is, but with the vibrator. And this is, he's making a darn good living at this, and his wife is, in his opinion, happy and healthy and is in no need of this treatment whatsoever. She, however, is having a horrible, horrible time, and is having a horrible time connecting with her husband, and her husband has no idea that this is a problem whatsoever. Everything's fabulous. So, and then we have a patient and her husband who come into this, and we have then all the relationships and problems and challenges that ensue. Also, another patient is the male artist that Alison referred to. And it is a beautiful mix that allows us to explore the relationships. It allows us to explore the time, and it allows us to explore sexuality of both men and women in a way that is strangely not titillating at all. It's really human and kind of amazing. And something that we don't get to do on stage, and in a pretty direct way. We do it in novels a lot, and in film some, but in a very visceral way. We get to do it with theater. So that's what is kind of amazing. I was reading something about the playwright where she said she thought that when she wrote this play, it was going to be not one of her big old hits. She wrote it for a group of theater artists, and she thought it would kind of, be done at this theater and then sink into obscurity. And she was shocked that it is being done all over the country and being so appreciated. And what she found is it's because it's speaking to a place that people don't get to talk about. So the fact that people want to explore female sexuality in this way, big thing, shocking thing, but people all over the country, theaters all over the country are doing it. So want to say that you guys are here and want to talk about this and think about that, important. So that's one thing to consider. And that this play is being done all over the country a lot is another thing to tell us that this is an important thing that people want to think about and grapple with. All right, I think, what else do I want to tell you? Want to talk about that what I do as a director is I'm the captain of the ship, and I work with trying to make the decisions of the storytelling, make sure that we're all telling the same story, and what you see on stage is my decisions of all of collaborators have come together, and I say, yes, we have told this story. That's basically what I do. So one of the things that if you come see the play, you'll see that, yes, the actor will literally have a paroxysm, which is an orgasm on stage from a vibrator. Of course, it's a fake vibrator. But it happens with both female patients and a male patient. And want to tell you how intimate this was and a difficult thing for an actor to do. It was very upfront when we had auditions about we were going to have to do this, and everybody had to, of course, working on the entire piece, how everybody had to be upfront about they would honestly be able to work in such an intimate way. And what it ended up to be was a very vulnerable, personal thing. However, I thought we were going to do it in a way that usually it happens with a stage manager, that you're in a rehearsal process, stage manager there, the director and the actors, and it ended up that working in such a personal thing that it ended up to be with just me and the actor. And why I'm telling you this, I guess, is how deeply personal someone's sexuality is, in that we are still so much, we think we're so free. I guess that's what I'm saying. We think we're so free and able to talk about sex, and we're not. These people had signed on, to, and were fully aware of what was in this play, and yet we're still not completely willing to have a rehearsal, even though we had done it so many times, read through a scene, I would say 20 times. But that one intimate rehearsal where we were going to make a sound of what it would sound like to have an orgasm, that rehearsal had to be private. After that one rehearsal, they were fine. And you'll see incredibly beautiful and actually funny acting about having those climaxes. They're really wonderful. But it's so revealing what that was like that it had to be private. So I guess what I'm communicating to you is in your work, you need to consider how incredibly private we still think this is, and intimate, and how careful we have to be. Anyway, I think I'm going to step down. All right.
So I'm Anita Clayton. I'm a psychiatrist here, and so I want to preface this by saying I'm a scientist, in that I think that sexuality and sexual function and sexual health and even sexual dysfunction is extremely similar between men and women. And so the fact that we see differences has to do with context. and mostly culture. And that's what we're talking about, and I'm going to address that to some degree. You know, as we heard, hysteria was believed by ancient societies to really be related to a wandering uterus. And then in the Victorian era, it was related to congestion due to anorgasmia. And if you think about it, arousal is all about congestion. And so if you don't have an orgasm, you have that persistent arousal. And so there are sort of elements of truth to this. But there's also differences, and differences across culture. And sex in America is also contextual. Now here, we think sex is everywhere, right? We see it everywhere, in movies and TV, in media, on the street, just everywhere. And 99% of the population is sexual at some time in their lives. So this really impacts on everyone. We also think we know who's sexy and who is not. And sometimes we attribute that to sort of being sexual beings or having a great sex life if you look sexy. Those things don't really seem to be very related. We also believe that everybody else is better at sex or having more fun with sex than we are. And the reason we believe these things is because we don't talk about sex in a serious manner. It's not really a legitimate topic. We don't talk about it even with our partners, and we don't talk about it much with our healthcare providers. So I'm going to talk mostly about this issue, about talking about sex, sexual health, sexual dysfunction in the context of medical care. One of the things that I hear all the time is people don't know what is normal when it comes to sex. And that's, again, because we don't talk about it. We get sex education, but that's about anatomy and about, like, put this there, and that's your bit. You know, how you experience that doesn't get talked about very much. And while most of us don't have a sexual dysfunction or a sexual disorder, many of us are still not satisfied. So as in the play, in the next room, because we don't talk about sex like we do other health-related issues, we lack awareness of our own sexual selves. And even those of us that do have an understanding about our sexual selves, there's a cultural limitation on expressing our desires and having our needs met. And that seems to be especially true for women. And you alluded to that also. We did already hear that Victorian culture is androcentric. It's reproductive focused. It's paternalistic. And it's sexually repressive. And we'd like to think we've come a long way from that. But I don't really think so. America in 2013 is more partner-centered, but it's still not gender equal. And there's lots of examples of this. From a doctor's point of view, from a medical point of view, there are multiple medications and procedures approved for treatment of the most common sexual dysfunction in men, erectile dysfunction. And we see it advertised on television, even in prime time now, right? Before that happened, you never even saw a tampon commercial on television. Okay, so even talking about normal women's function related to reproduction was not talked about on television. And some of these drugs have been approved after only 250 men have been tested. Rush to treatment. Let's make those drugs available. On the other hand, there are no medications approved to treat the most common sexual disorder in women, hypoactive sexual desire disorder, or distressing low sexual desire, that affects about 10% of U.S. women. And this is true despite efficacy and safety having been demonstrated in thousands of women. Thousands. One drug, 10,000 women, still not yet approved. Also, the recent struggle for approval of Plan B, or the morning after pill, and also attempts to limit availability of contraception reflect cultural bias. Of course, if women don't have contraception that they control, like the birth control pill, then they're maybe less likely to go out and have sex with somebody else. They may be less likely to get pregnant by somebody else, except they're more likely to get pregnant if they're doing it at all, right, if they don't have birth control. And the fear is that women will, our sexual desire gets out of control. That's what nymphomania was, and that we might have sex with just anyone. And of course, that's not allowed, but it's okay for men to do that. So we have a lot of these limitations, and there are also other limitations related to this. There are religious prohibitions. There are family prohibitions. So it's not just the societal or cultural context, but those are all applied on top of each other. Some are more personal than others. So this cultural limitation applies to healthcare providers as well. So physicians from the Victorian era, like Dr. Gibbings, this is his name in the play. This cannot be a joke. He's given it to them. This cannot be an accident. Dr. Gibbings didn't talk with his patient, and neither did other providers at the time, about their diagnosis or the nature of the treatment. They're not aware what he's attempting to bring about. And there's certainly no real informed consent. Okay, he basically sort of says, get in there, do this, turn this way, and they're kind of reluctant and concerned because they don't know what's going on, they still do it. And even today, unfortunately, physicians are poorly educated about sexuality. There was a study in 1997 of US and Canadian medical schools that found that about 92% of schools offered core curricula in sexuality. This averaged 11 hours in the 4 years of medical school. This is in 97. Okay, in 2003, another study was done and found that US medical schools provide between 3 and 10 hours of instruction over the 4 years. So we've actually lost ground since 1997. And I'm hesitant to see where we are in 2013. Very few specific human sexuality courses are offered, and almost none are required in medical school. What this means is that healthcare providers lack knowledge about sexuality, about sexual health, about sexual dysfunction. And physicians also have we have our own culturally mediated attitudes, personal attitudes regarding sexual behaviors. And that includes sexual desire. And you can't take those out of the room because they're part of us. So those impact on our ability to take care of patients. There's also a very low comfort level with talking about sex with patients. And this is true about other areas that may be seen as personal or intrusive. But our comfort level, knowledge probably can be changed first. Then our comfort level with experience may be changed. And finally, our attitudes are probably the last things to be able to be modified or changed. It turns out we're particularly uncomfortable dealing with patients whose desires and behavior fall outside of culturally determined limits. This has the potential to negatively impact patient care. Studies show, though, that patients want to talk to us about this, okay? That when the topic is broached, most of the time it's brought up by the patient. However, a study also showed that 3/4 of patients who wanted to talk about sex and who had sexual concerns with their doctor thought that their doctor would be uncomfortable if they brought up the topic. And they felt badly about making their own doctor be uncomfortable. Another 3/4 thought that their provider lacked expertise in this area after they brought it up. Probably true. And that the clinicians had little to offer. Probably true too. We don't have that many treatments or interventions, or we don't talk about it. It's hard to set up referrals for patients for these kinds of problems. And we've studied this even among doctors here at UVA, and doctors do acknowledge their lack of knowledge and their discomfort, and so they avoid the topic. This must change. As in the Vibrator play, knowledge is power. And that gets at the feminist issues, or at least equality, some kind of equality, not even radical thought at all. Healthcare providers have to make sex an acceptable topic to be discussed in a medical visit. How do you do that? I'm aware that some people have put up signs about domestic violence discussed here, and that actually allows people to broach that topic, and then sometimes concerns about sexual abuse have come up. We can give permission to patients too. We can introduce the topic, we can present it in a situation in which they're not coming in with a specific complaint. That's another thing. When they come in and they have a specific complaint, that's not the complaint that they register at the desk, a sexual complaint. They say some other problem, and then doctors all complain about this. Just as they're leaving the door, the hand on the doorknob scenario, the patient brings up the topic because they've been waiting, trying to get their courage up. We've got to change this. So we've got to broach the subject. And we need to do it in settings in which it's not just, are you having difficulties? It's more about, how is your sexual life? Let's talk about that, because that's important in the context of an initial evaluation, initial history and physical. It's important in the context of routine pelvic exams. Good grief, you're examining that area, and then you're probably prescribing birth control pills, and most of those people are using the birth control pills for contraception. So they're probably having sex, and we ought to be talking about that. Hypertension follow-up visits. We ought to be talking about it there, because that's often men and women at ages in which their hormones have changed. They've got cardiovascular disease. That impacts on sexual functioning, and so do the meds we give them. And I'm a little hesitant to say this, but it's very important. In well adolescent checks, everybody wants to think if we don't talk about it, the kids won't be doing it. Not so. In addition, we need to respond to all patient questions and complaints. So people may come in and say, sex is painful, it's dry, I'm having trouble now with my erections. We need to respond to those. And not in sort of a paternalistic way like, yes dear, of course you don't have any desire because you work, you have 3 children, a husband, and you've got all these things to do. Well, the message there is for us to prioritize sex pretty low on the totem pole. And so we really don't get our needs met in that context. We also need to listen non-judgmentally. And most of the time, we don't even really need to know what people are doing, just what happens when they do it. And in that way, I think we can be not judgmental, even if our own personal attitudes toward these behaviors are different. We also need to educate, and we can't do that if we ourselves are not educated. And finally, I would say we need to offer something, even if that's just more opportunities to talk. Thank you.
Good afternoon. So my name is Anne Talbot. I'm a medical student here in the graduating class, and I'm also the producer of the show. Thank you, Dr. Childress, for the chance to speak here today. And I think what I want to try to do in the next 10 minutes is kind of give you a little bit of the student perspective and why I chose to be involved with this particular show. So I've actually started going volunteering at Live Arts because I wanted to do something that had nothing to do with medical school. I needed a break really bad. And so I thought, great, you know, I can learn about stories and learn new skills. And actually what I found out was that theater is in a way not only complementary to medicine for me, but also a continuation of it. Theater and plays about medicine, plays about science, and plays about health, such as the Vibrator play here, for me are really an opportunity to kind of reflect about what I learned in school and what I do, you know, when I'm in the clinic and I interact with patients, and think about how do I want to be down the road when I'm the primary physician and I take care of patients. And so I love those opportunities. And also I think in a story like this one, hopefully you'll get to see it, a lot of it has to do with empathy. And so for me, when I go to the theater and I sit and I watch a show such as this one, I really kind of get a chance to think about how do I feel about these patients? Because often I think for those of us who are healthcare providers, we're so busy thinking about the science and what we need to do in diagnosing and all that, we don't take the time to really kind of check in internally and say, okay, well, how can I better relate to this patient? How does that make me feel? And it's true, we're really busy, our clinics are packed and so on and so forth. But when we take the time to sit down in a dark room and see an interaction that is very much like what we would see at work happen, then you can actually check in and think, okay, how does that make me feel? And then I think that really informs how we go about, being better clinicians and better healthcare providers. So, sure, sorry. But I also want to kind of broaden the issue a little bit and build on something that Dr. Booth mentioned. So I think, the theater tells stories, right? We hear, people's stories. But if you think medicine is also a lot about stories. So again, there's a great parallel here. But like Dr. Booth said, at the theater there's a safe distance. So there's a historical distance in this play. We can talk about sex in the Victorian era. It's much easier to talk about sex and sexuality now in 2013. Okay, so same thing if you think about it, for me, that distance is very important in sparking conversations with like a greater public. So if I go to the show with a friend of mine, we can start talking about what we saw on stage, and maybe that, basically opens the door for a big conversation about what's going on in our lives. Or maybe, friends have brought something up, and so it just opens the door for those conversations. One point I'll make about that with this particular show is, when we started working on the show, we knew that, some people may not want to come see the show, that the topic would be, displeasing. And so when we created this poster that you see here, we took it around town, we said, to businesses, would you like to please advertise the show? And, this community has been wonderful supporting live arts across the years. But I will tell you that there has been a few businesses who looked at this poster and said, no, can't do, we won't display that, okay? So that's kind of one end of the spectrum, is refusing to even display the poster, which, so, but that's okay, because even by saying no thank you, we're still talking about it, right? So that is still a good thing. And then the opposite end of the spectrum is that just the other day at Live Arts, we had a partnership with a group in town called the Women's Initiative, a group, an advocacy group, and they're very interested in promoting women's health. And so we had a joint event with them for the community, talking about these issues. So you see, the conversation really kind of can go all directions. So I think that's really exciting. And that's certainly something that I really enjoyed about being involved in this venture. A little more specifically as to why I wanted to work on this show. Well, first of all, because it's about medicine and it's about science, and I'm a future physician scientist, so that's right down my alley. So that's great. I think it's a wonderful tool to educate the public about what it means to work as a physician. Certainly, you see that in the play. It just also brings up all these important topics, so it's a great educational piece. But what I also love about this particular show, is a lot of what you see is from the perspective of the patient. And so again, as a future physician, if I can try to put myself in the patient's shoes, I'm going to be a lot better, when they come to see me, I kind of understanding what they're going through. And so that makes me, I think, more perceptive. That also helps make me more compassionate. So I think that's a wonderful thing. And then the other thing I love is how does society look at us, physicians and healthcare providers? So Sarah Ruhl is a playwright, right? She's not a physician. She clearly had done a lot of research, but I think the way she portrays this Dr. Gibbings really kind of gives us an idea of how greater society thinks of us as healthcare providers, and we have to learn to, there's lots to learn about that, right? How do people perceive us? Because the way they perceive us is going to influence what they tell us, right, when they come into the office. So just like Dr. Clayton mentioned, if they think that we don't know a thing about sexual health, or we're not competent, or we're going to be embarrassed, obviously they won't bring it up in the first place. So that's, I think, the next thing. That's just a great thing. Okay, and then lastly, I really wanted to talk about, as a student and thinking about my fellow students, how can we use theater as a tool to basically further our education? Okay, so the first thing is, again, you see this play, you see these patients, you see these stories, and you think, wow, it's really hard for a patient to have to go through that. It's really hard, so now I understand that better. But then also, when I was reading the play, watching it being rehearsed, those real intimate moments that Julie described, and then when the play opened and seeing the whole thing, how did I feel about it? And what I found out is that I have my own biases. So I've become very aware of the things that I'm not comfortable talking about, when it comes to sexuality, sexual function, and dysfunction. I know I have some fellow students here in the audience I mean, we've all had encounters as students where, a patient brought up a complaint, and that happened to me just last week, and I mean, I was ashamed almost that it took me 2 seconds to kind of just, compose myself and then be able to start the conversation. So it's a great experience because, again, I'm more aware of it, aware that I need to work, more on it. But I think having, a show like this one, and like we did on Saturday when we brought some medical students over to see the show and have a conversation about it, we are using a whole new approach to basically further our education. Here at UVA and I know at a lot of other medical schools, we use standardized patients a lot to learn how to interact with patients, take histories and do physical exam and whatnot, and that's a wonderful tool. I enjoy it. But I would argue with you that this, even though maybe there's less direct interaction, is also a wonderful tool to learn about how to be a physician, how to listen, how to be more empathetic, and basically how to care. I think I just want to leave it there and open it up for questions at this point. But the opportunity that I've been given through Julie, through Live Arts, to do this, I really believe has been wonderful because it's made me more aware as I'm about to graduate of all of the things that I need to pay attention. Because in a few months I'm going to be out there and people are going to come to me and ask me those real questions, and I need to be ready. And so in this way, this has really prepared me even further to do that. Thank you.
Thanks. We have plenty of time for some conversation with you about what you've heard here or what some of your questions are, what you'd like to know about the play, about the culture, about the Victorian era, about the connections between drama and medicine. So John will move through the auditorium with a mic, and I would ask that before you ask your question or make your comment that you please identify yourself.
I don't need a mic.
Well, we need it for on the recording. So.
I don't so much have a question as just a comment that I used to run the Planned Parenthood in Roanoke, and I would like to say I think we're really great at talking about sex, actually, because we're in a situation where I was in a situation where people were coming to us saying, "I'm here to have an abortion." And you're telling me that in my self-care afterwards, I can't have sex for a while. What's the substitute behavior for that? And what, if I can't have vaginal sex, what kind of sex can I have? And so from physicians to our front desk people to our lab people, we were all really good, I would like to believe, at one, really pushing being non-judgmental in our conversations with people because obviously people were also coming to us for testing. And because they had various STIs. And again, we wanted to be able to talk about what sex can look like, even if you have this situation. So I think that there are lots of opportunities where people, where clinicians and non-clinicians who are in this field are self-educating or just being exposed to these conversations and are therefore able to engage in these conversations with people. And I hope that maybe the play will encourage others to expose themselves and be able to open up conversation.
Hi, I'm Chris Peterson. I'm one of the gynecologists at Student Health, so I spend all day, every day, talking to our former freshmen about their sex lives. And I just wanted to talk about how useful external things can be to the conversation about sex. So the play, for instance, and then there's a wonderful resource that the medical students in here may have heard me talk about, but that everybody in this room should know about. And I'll tell you a little story about how it was useful in talking with a patient, as Anita mentioned, who had other concerns, but really wanted to talk about a very particular sexual concern. And the resource is a book that's called The Guide to Getting It On. And it's published by Goofy Foot Press. And if you Google it, it'll pop up. You can buy it through Amazon or directly through Goofy Foot Press. And for those of you who are older than 40 and remember The Joy of Sex, well, The Guide to Getting It On is The Joy of Sex, but for the millennials. It's about 4 times as thick, It is extremely explicit. It's wonderfully written. It's written by a psychoanalyst. It is very, very sex positive, very, very detailed. Talks about every aspect of human sexuality that you can imagine in a very relational way. Anything you want to do is fine as long as your partner agrees to do it, and it gives really very accurate information. So some time ago I had a patient who was a student and had come in for some gynecologic concerns that were beginning to head towards contraception and sex and so forth. So we were talking about that in some depth. And she asked, she said, well, where can I go to learn more about this? So I directed her to the book, and I brought the office copy of the book into the exam room with me. She took it into her hand, she immediately went to the index, and she found the chapter on sadomasochism. And she said, if you're willing to hand me this book, then I can ask you the question that I came here to ask you, which was about we are using whips in our relationship, and they draw blood, and do I need HIV testing even though I'm not having intercourse, but because I'm sharing something that results in my exposure with blood to another person? Really, really important question that she had to ask. And of course, yes, she did need HIV testing, even though she had never in her life actually had intercourse up to that point. And so my point is just that there are some really interesting and wonderful ways in which the external world and publications and plays and so forth can help us have conversations with our patients, and to be aware of them and have access to them can be very, very useful and perhaps even life-saving.
Can I just say that, anything you and your partner agree to do, one of the things I like about the Sarah Ruhl plays is she doesn't make it sort of simple lack of power on the part of the women. It's just incomprehension and miscommunication. And I took it that, Julia, you were trying to direct a kind of, that that Mr. Daldry is a bit of a sadist, or, he's dominating his much younger wife. She doesn't really have much say, and that's just, it's easy enough to talk about consensual sex, and then when it happens that you don't know how to say no to your partner, that's a whole set of issues. But not even knowing what you desire is the other couple's problem, and the play ends very beautifully with a kind of exploration. The only thing I would wish is that in 2013, 2009, she could be even more explicit. The playwright could be even more explicit about the lesbian relationship. That would make me happy, not as a lesbian, but as just, this is clearly what's going on. These women can't articulate it in 1880.
Yes, there are all kinds of relationships in this play. Yes.
But well treated by the playwright.
Hi, my name is Anne-Laure, and I just wanted to sort of share what I've experienced this week. Coincidentally, on Friday, I watched the movie Hysteria that I had rented through Netflix, which I found immensely interesting because as a clinician and just my interest in history and medicine and those two together. And so I texted my good friend sitting here beside me about this incredibly interesting movie about the physician in the 1880s who invented the vibrator, but as a medical device. And then she texted me about the play. So the very next night I went to see the play with my husband, who was a little uncomfortable with the play, but I thought it was amazing, and it explored so many aspects of sexuality and health and women and what we're feeling. And I just wanted to share that I felt one of the most interesting parts of the play was when the two women, the American white women, were there in conversation with the black, the white nurse, yes. And they were talking to her about, have you ever felt these feelings where you're feeling pain and you're feeling pleasure and you're tingling? And then she said, from a different culture, well, sometimes people feel that when they're having relations with their husbands. To these women who were getting this treatment, it was not at all seen as sexual, but as something medical, and it was not at all linked to any intimacy with their husband. And it just really brought to light about the differences among cultures in terms of sexual behavior, sexuality. And so now getting back to physicians and treatment and healthcare, my question is in general, what have you noted, what can you say in terms of seeing a variety of patients from the different cultures and their comfort level with discussing sexuality? There's our culture, but then there's other cultures.
Yeah, we're picking up some kind of reference.
Well, obviously, again, we have a genetic predisposition, we have genes, and then we have environmental and internally biologic, but that's also environmental influences on those genes that lead to the phenotype, that whatever is going to happen. And a lot of those external events can be culturally mediated and shared events, or information, or they can be non-shared types of events. Interestingly, it looks like it's non-shared events that influence sexual dysfunction. So presumably shared events have something to do with just sexuality and sexual health. Although not always, because if you look at what's happening in our culture with regard to sexuality, I think that we still have a ways to go. A study looked at 29 countries around the world and asked the same kinds of questions about sexuality and things like that, and they found that there were three groups. There's more partner-centered societies, which is North America and Western Europe. There were sort of macho preference, but not negating partner relationships that were related to Brazil and the Mediterranean areas. And then there were Asian, predominantly Middle Eastern and Asian countries that were really male-centered and reproductive focused. And the level of complaints was very different in different cultures. And so there is an impact of culture. In addition, we've studied women who have postpartum depression and urinary problems, and found that there are sexual issues related to that. We've studied, we've looked at women in the Latina clinic here and found differences in terms of prior sexual experiences, including sexual trauma and things like that. So again, coming from a different culture. So we absolutely need to take culture into consideration. I can tell a story about my children that I mentioned. We spent a summer in France and Italy, and my son was 9 and my daughter was 6, and we went to a local pool and we were going to beaches and things like that. And before we went, I said, look, some women will take their tops off here. So don't act like idiots, or ugly Americans, and don't point or do something like that. Well, so the first time we went to the pool, 2 women in their 50s sat down, took their tops off, and my kids went. Like, okay, good, you're not pointing, but you're going to catch a bug. So the next time we went, they didn't do that. Same thing happened. It might have even been the same women. They looked and they said, "These women took their tops off." I'm like, yes, they did. We've talked about that. The next time we came back, they looked. They said, "Those women shouldn't have taken it." So they went in 3 times from being, kind of shocked to being interested to being critical. And, that's a different culture because nudity is totally different there than here. And so we do adapt to these cultural differences, and we need to adapt too as healthcare providers.
We've come to the close of our hour, but one of the things, just to tie in with what Anita Clayton was just saying, I feel like we've also done some culture bridging here because we've brought this conversation into the medical culture, which when you see the play, you will see that medical culture is quite different from domestic culture. even though they're in the next room from each other. So we hope that you will go to see the play. It's here on until the 23rd of March. We also hope you'll come next week to the Medical Center Hour when we'll be talking about the type 2 diabetes crisis. Can history help us address it? We've just seen that history can help us talk about sex. Maybe it can help us do something about diabetes as well. The speaker is Arlene Tuckman from Vanderbilt University. And we'll look forward to seeing you then. In the meantime, please give a hand for our 4 schools.